Good morning, everyone, and welcome to the April ISCRR Learning Series. I'm Janine McMillan. I'm an acting co-director of ISCRR, which is the Institute for Safety, Compensation and Recovery Research. And I'd like to welcome you all here today. Firstly, I wish to acknowledge the people of the Kulin Nations, on whose land many of us are based today, and the people of the lands that you're dialing in from today. Pay my respects to their elders, past, present and emerging. We extend that respect to First Nations people here today. For those who are new to the ISCRR Learning Series, each 2 months we present a topic on our research findings, the impact of our research and best practice management of research. And you can find out about future ISCRR events by joining our mailing list, and you can join through the evaluation survey that will appear when you leave this session. Our topic today is the clinical effectiveness of spinal cord stimulators for persistent pain. And that'll be presented by our Senior Research Officer in Evidence Reviews, Dr Sophie Pointer. Sophie has extensive experience in injury surveillance and started working in the field in 2002. Prior to ISCRR, Sophie was the Deputy Director of the National Injury Surveillance Unit at Flinders University and has extensive experience working across university and government sectors, both state and federal. Sophie has a keen interest in increasing the understanding of the nature, causes and effects of human injury and in reducing its occurrence and consequences. Sophie holds a PhD in neuropsychology, an honours degree of Bachelor of Science, as well as a degree of Bachelor of Science from Flinders University in South Australia, in the School of Psychology. And she's published numerous reports and high-quality scientific publications in refereed journals. Also joining us today is Dr Hugh Seward, AM. He's the Medical and Recovery Director at WorkSafe Victoria and the Medical Lead of the Transport Accident Commission's clinical panel. Hugh has worked as a sport and exercise physician and a specialist GP in Geelong for 41 years and within the AFL industry in various clinical, research and leadership roles. So I'm going to pass over to Sophie for our presentation, and then Hugh will be speaking straight after Sophie from more a WorkSafe Victoria point of view. Over to you, Sophie.
Okay, thanks very much, Janine. And also I just want to shout out for Jimmy for organising today's presentation. So today I'll be talking with you about the clinical effectiveness of spinal cord stimulators for persistent pain. And we're coming really from an evidence review type perspective today. So in the presentation, I'm going to be discussing what spinal cord stimulators are, what are some of the key issues around their use, what's the current evidence base for the use of spinal cord stimulators, and what's happening in the regulatory space in Australia. So what are they? Well, they're neurostimulation devices and they're used to treat chronic or persistent back or leg pain. They have a history here in Australia and the first procedure was performed in 1967. Well, certainly here in Australia. And as of 2022, there were around 9 commonly used spinal cord stimulator platforms and they were made by 5 manufacturers. And the image you see here on the slide are some examples of some spinal cord controller devices. So how do they work? Well, the image that you see on the screen now shows you the basic layout of a spinal cord stimulation device and leads within the body. The thin wires, which you can see leading from the device, are placed in the epidural space alongside the dorsal column of the spine. And the electrodes are then connected to a generator or a controller. The generator itself, it's surgically implanted under the skin. It's usually near the buttocks or the abdomen, but it can go in other places. And you can think of generators as similar to pacemakers. They contain a battery and a microprocessor. Now, the implanted devices transmit mild electrical impulses to the spinal cord, blocking the pain signals to the brain. And the process is thought to work via the gate control theory of pain, but there's still a bit of question marks around exactly how they operate. Now, initially, spinal cord stimulators are generally trialled for a week prior to permanent implant. And in these trials, the controlling device is worn outside the body. And patients who achieve greater than 50% pain reduction after their trial usually go on to have a permanent implant. So without getting too technical, each stimulator has several unique features and indications and limitations for use. So for example, there are rechargeable and non-rechargeable controllers, and there are also various different types of leads that people can use. Now, there are currently 4 main types of stimulation available. The first of these is called tonic. It's a traditional form of stimulation, and it operates at a very low frequency, but it also induces a form of paresthesia, which is kind of like a tingling sensation or pins and needles, and people can feel that when it's operating. The other 3 types of stimulation devices don't necessarily induce any paresthesia, and they operate on different frequencies with different modes of delivery. So for example, the burst mode of delivery delivers continuous bursts of stimulation, and again, there's no paresthesia. And then the more recent devices, such as closed loop, the closed loop system measures the evoked compound action potentials, or the ECAPs, and it drives a feedback loop and maintains a certain amount of amplitude. And again, there's no paresthesia associated with the use of the closed loop spinal cord stimulator. So the context or the type of pain which I'm talking about today is essentially back pain and some leg pain. Chronic or persistent back pain can have many different causes, and spinal cord stimulation is commonly associated with these 2 conditions: failed back surgery syndrome and complex regional pain syndrome. Now, failed back surgery syndrome, it describes a condition of patients who've not had a very good or successful result with back surgery or spinal surgery, and they continue to experience pain as a result. For complex regional pain syndrome, it's a form of chronic pain that usually affects the arms or the legs. It typically develops after an injury, surgery. It can develop after stroke or a heart attack. And the general feature is that the pain is out of proportion to the severity of the initial injury. And in both cases, it's very difficult to treat the pain associated with them. Now, when you look at the literature, there's also a long list of other non-specific types of pain described, such as chronic low back pain and non-surgical refractory back pain, and people often use terms just like back pain. So in addition to the reductions in pain, spinal cord stimulators are also suggested to have secondary effects or secondary outcomes in a number of other areas of people's life. And primarily this is to do with improvements in pain tend to lead to improvements in disability and function, can also lead to improvements in quality of life or health-related quality of life. They're also thought to lead to reductions in the use of pain medications, which makes sense because if you're reducing pain as a result of having a spinal cord stimulator, you shouldn't need as much pain medication. They're also thought to improve people's capacity to return to work. So some of the key issues associated with spinal cord stimulator use in Australia that we need to be aware of include things like the financial implications. They're not inexpensive, costing between $30,000 and $40,000, but you also have to factor in some maintenance costs and also costs associated with revisions and replacements. Technological advances is another key issue to think about. This is an area where there are rapid advances in technology, and what this means is that there is less replication. So somebody carries out a study on one particular form of spinal cord stimulation, and when a new form comes out, they're less likely to go back and look at the effectiveness of the first form of spinal cord stimulation. And this also leads to a lack of long-term outcome studies as researchers move on to the next device that's available on the market. Another big thing to consider when talking about spinal cord stimulators is the range of adverse events. In the literature, there is a range of complications associated with spinal cord stimulator use, but we also know that there's underreporting of adverse events and complications associated with the devices. And then the other key issue to consider is the evidence base, which is essentially what I'm talking to you about today. What is the evidence for the effectiveness of spinal cord stimulators? What do we know about recent research? What's the quality of that research? And have there been any important reviews released lately? So last year, ISCRR commenced its own evidence review on the literature on behalf of WorkSafe Victoria in order to examine the effectiveness of spinal cord stimulators on persistent pain. Now, this slide is very busy, but I don't want you to be too focused on all the little boxes. Really, the information that you need to take home is that we looked at 3 major databases, and together those databases reference thousands of individual journals. We also included systematic reviews of randomised control trials, but we also had a look at some prospective clinical cohort studies. We included research if it was published between April 2014 and August 2022. And we also carried out formal quality appraisal on the systematic reviews and the randomised control trials. Now, the review itself was confined to examining compensable type conditions. So not all conditions that spinal cord stimulators are used to treat were actually included in the review. And this is pretty much what we found. We found 51 papers, which is actually quite a lot for a evidence review. 21 systematic reviews, an additional 10 randomised control trials not included in those systematic reviews, and 20 prospective or clinical cohort studies. Now, I should point out that we did find a Cochrane systematic review that was published very recently in 2021. And of course, this is really one of the highest levels of evidence that you can get when evaluating health outcomes. Now, we did actually notice that there was another Cochrane review published about a month and a half ago, and this particular Cochrane review was too late to include in the current evidence review, but as I go along, where relevant, I'll mention its findings. Now, on average, these systematic reviews looked at a combination of randomised control trials and other types of control trials. They averaged between 10 and 15 papers, and many of those papers were the same, so the same systematic reviews reviewing the same publications over time. Most of the systematic reviews and randomised control trials focused on an outcome of pain, but there were others looking at other aspects, including opioid use. Now, this chart I'm showing you now is taken from a paper by Harmson and colleagues, and they were looking at the number of registered clinical trials of spinal cord stimulation that had commenced since the late 1990s. And what you can actually see is an exponential growth in the number of clinical trials and associated reporting. So approximately 2/3 of all clinical trials have commenced within the last 5 years. And this is going to lead to an increase in reporting and publications on the subject. As these active recruitment periods go down to completed, we'll be seeing more and more evidence about the effectiveness of spinal cord stimulators. So the primary outcome that we were examining in the evidence review was the effectiveness of spinal cord stimulators on pain reduction at 3 time periods. So we were interested in how effective they are in the short term, the medium term, and the long term post-permanent implant. Now, the short term covers the time immediately after permanent implant up to 3 months later. Now, some RCTs and other studies do actually look at outcomes within a week of permanent implant, but on average, it's around 3 months. So overall, we identified 4 distinct RCTs, distinct from the systematic reviews, and 4 systematic reviews that looked specifically at short-term pain reduction. Now, all but one of the RCTs reported statistically or clinically significant improvements in pain outcomes. But unfortunately, the quality of these studies were low or medium quality. So overall, we concluded that there was a moderate evidence base, but that support would have to be moderated by the quality of the papers. Now, the medium term covers a period of time between 3 months and 6 months. Generally speaking, most RCTs do report at 6 months. There was limited evidence from an even smaller number of randomised control trials. The Cochrane review found the 2021 Cochrane review found a clinically important mean difference at 6 months based on 5 RCTs. Those RCTs were comparing spinal cord stimulation combined with medical management to medical management alone. But unfortunately, the evidence for those studies was graded as being of low certainty. So overall, we identified that there was low to moderate evidence available, but some moderate support for the effectiveness of spinal cord stimulators in reducing pain in the medium term. Now, the long term covers time points from 12 months onward. And while the number of systematic reviews reporting on long-term outcomes was quite high, we only identified 2 randomised control trials. And the systematic reviews themselves had a very small number of randomized controlled trials that actually looked at outcomes. Most of the long-term outcome research is based on prospective cohort studies. The Cochrane Review, the 2021 Cochrane Review, found one study, one RCT, that demonstrated improvements in pain up to 24 months. But unfortunately, they graded the evidence in that study as being of very low certainty. They identified serious limitations of imprecision and inconsistency in reporting. And our own evaluation of the RCTs found studies of very low quality. So overall, in the long term, we found very limited evidence and quite limited support for the effectiveness of spinal cord stimulators to reduce pain in the long term. Now, as I mentioned earlier in the presentation, there was a very recent Cochrane review published that looked at spinal cord stimulation. Now, we need to point out that the review only examined the effectiveness of spinal cord stimulation on low back pain and compared to a placebo group. They identified 13 studies and had a total of 699 participants in them. Most of the trials that they looked at were less than 1 month in duration. They did find one at outcomes at 6 months. Overall, they found moderate certainty evidence that spinal cord stimulation probably does not improve back or leg pain compared with a placebo. The authors concluded that the data don't support the use of spinal cord stimulators to manage low back pain outside of clinical trials. And they suggest that spinal cord stimulators probably don't have a sustained clinical benefit that outweighs the costs and risks of the surgical intervention. In many instances, the published randomized control trials had limitations that affected the level of support that could be attributed to their findings. And these limitations include things like selection bias. So we had participants who were already stable and using spinal cord stimulation devices included in studies. There was a lack of blinding. There were high levels of withdrawals and dropouts. There's a very large amount of industry funding. It's not unsurprising in clinical device research, where large amounts of money are needed to run these large clinical trials. But that funding was associated with authors as well as funding of the base study. There were very small case numbers in some instances. Again, this is not particularly surprising for clinical studies, but it is a concern in terms of limiting the generalizability of the evidence. And there was very high heterogeneity in the research. So basically, when there's high heterogeneity, I'm doing well today, aren't I? Heterogeneity in RCTs, you limit the comparisons and the impacts, and this impacts the level of evidence ratings in systematic reviews or in meta-analyses. Heterogeneity occurs between study designs, so control, no control, spinal cord stimulation modalities, so including spinal cord stimulators that are delivering different types of stimulation, like tonic or burst, control groups, and included pain conditions. And as the pace of change in device development increases, we're seeing less replications to confirm original findings. Basically, device manufacturers move on to fund different spinal cord stimulation parameters and devices. Now, as a result of these types of key limitations, O'Connell and colleagues said they rated the evidence overall as being of low or very low certainty. So they really identified limitations in how studies have been conducted and reported, and the amount of evidence we found and inconsistencies between studies in some instances means that our confidence in the results is limited. So if we take a look now at the evidence for the suggested secondary effects of spinal cord stimulators, and we'll start with improvements in disability and functioning. And this is what the evidence review found. There's a very small evidence base, mostly based on analysis of secondary effects or outcomes. So what this means is that RCTs and other studies were primarily focused on pain reduction outcomes, and some looked at improvements in disability and function as well. Now, the Cochrane Review, the 2021 Cochrane Review, did find small significant improvements in the short term in terms of people's disability and functioning. And 3 of the systematic reviews that we looked at found positive effects on disability and functioning attributed to spinal cord stimulation. However, the evidence is extremely limited. There were very few RCTs, for example, looking at this particular outcome. And so overall, we were only able to provide weak support. In terms of improvements in quality of life, this is primarily measured as health-related quality of life. Some of the systematic reviews reported on quality of life as a as a secondary outcome. We did find 2 randomised control trials that looked at health-related quality of life as a primary outcome. Cochrane review found a small significant improvement in quality of life in both the short and the medium term. And the systematic reviews all reported positive effects on quality of life attributed to spinal cord stimulation in the short and medium term. And all the RCTs, the 2 RCTs that we found, reported improvements in quality of life at various time points. So despite, again, there being quite limited evidence, there was actually more consistent moderate support for the idea that spinal cord stimulators can lead to improvements in people's quality of life. So if we turn now to pain medication, I should point out that the measure of pain medication in the literature varies quite significantly. Some people report on a generic category of pain medication where it's not further specified in terms of dose or type of medication, and others are quite specific, looking only at one type of medication, for example, opioids. It's a very small evidence base again. We found 1 systematic review, though, that did report on medication use as their primary outcome. So they focused very specifically at examining RCTs and other trials to see what the effect of spinal cord stimulation was on medication use. The Cochrane review itself actually found no evidence of spinal cord stimulation on the reduction of pain medication use. And the systematic reviews and randomised control trials that we included found some positive effects of spinal cord stimulation on reduction of pain medication in a more generic sense. That systematic review that looked specifically at the outcomes in terms of opioid use found that the largest reductions in the use of opioids was found in people who commenced spinal cord stimulation on low doses of opioids. They suggested there was some sort of dose-dependent relationship, so that people who entered a spinal cord stimulator study on very high doses of opioids had very smaller impacts on their use of opioids post-permanent implant. So again, very limited evidence, not much in terms of focus on reductions of pain medication, but there was some evidence of moderate support that spinal cord stimulators can lead to reductions in pain medication. And for opioids specifically, people on low doses of opioids tend to have better outcomes in terms of reducing their pain medications as a result of spinal cord stimulators. In terms of looking at improvements in return to work, there was not a lot of literature looking at return to work capacity post-permanent spinal cord stimulation implant. We had a systematic review that found a few studies that reported a return to work mean of around 14%. We also identified 2 other studies that reported a percent return to work of 14% and 21% 12 months post-permanent implant. Now, the evidence base here is quite limited because we didn't have much information on whether that return to work measure looked at whether somebody went back to work full-time or part-time, casually, or whether they returned to their own career. There basically just is not enough evidence out there, so it's quite weak in terms of the support for improving return to work as a result of having a spinal cord stimulator. Now, the very recent Cochrane study did take a look at some of the secondary effects that we've been discussing, and they concluded that for people with low back pain, they were only moderately confident that at 6 months, spinal cord stimulation probably does not lead to better function or higher quality of life compared with the placebo. So not a lot of support coming from the very recent Cochrane review. So if we look now at the evidence base for adverse events, now there are a number of adverse events associated with spinal cord stimulators, including things like pain at the implant site and ongoing pain associated with leads. We know that there are high rates of surgical revision, infection, lead migration, where the leads that are placed in the spinal column can actually move and come out. And we also know there are issues with device malfunction and lead malfunction. And there are more serious cases, for example, internal punctures as a result of lead migration. Now, adverse events were discussed in the RCTs, most of them anyway. It's not always the case that randomized controlled trials report on adverse events associated with their trial, but the proportions that do report are increasing. Adverse events percentages across or reported by 3 of the 4 systematic reviews. So for example, pain, there were a number of RCTs that reported that there were no participants who experienced pain, where there are other RCTs where up to 27% of participants reported pain as an adverse event. Again, lead migration, number of studies that reported no instances of lead migration, and others that reported 15% of participants experienced lead migration. For surgical revision, there were papers that reported 29% of participants requiring some form of surgical revision during the trial, and 16% of participants in one trial required their devices to be removed or explanted. And we do know that rates of explantation or removal of devices are actually higher, according to Therapeutic Goods Association reports, than what we currently see reported in the literature. Now, in 2022, Jones and colleagues published an analysis of the adverse events reported to the Australian Therapeutic Goods Association between July 2012 and January 2019. During this period, they identified that nearly 27,000 spinal cord stimulators were implanted in Australia, and 10,702 devices were removed during the same period. Now, the authors spent time coding a range of adverse events using reports to the TGA and hospitalizations data. They coded events in terms of seriousness, severity, body system affected, type of event, action taken, attribution of fault. So there's quite a bit of information to unpack within their paper. Overall, they identified or classified 520 reported adverse events during this period. And they saw that device malfunction was the most common event. In over half of the adverse reported events were due to device malfunction. Now, they rated 79% of those adverse events as severe and 13% as life-threatening. And the authors estimate that each year in Australia, for every 10 spinal cord stimulators implanted, approximately 4 are removed. Jones and colleagues concluded that their results raised questions about the safety and utility of this approach to treating chronic intractable pain based on these high rates of adverse events. Now, the use of spinal cord stimulators have also attracted a lot of media attention lately. This is an example of 2 recent articles in The Age, which is a large daily media publication in Melbourne, Victoria. And as you can see from the headlines, you know that the articles are focusing on adverse events associated with devices. And certainly if you do a quick Google search, you will find many YouTube videos and other articles overseas that are reporting on people's negative experiences with spinal cord stimulators. So as a result of increasing reports and publications about adverse events, in November last year, the Therapeutic Goods Association announced it was undertaking a post-market review of spinal cord stimulators. So all the device manufacturers included in the Australian Register of Therapeutic Goods are going to be asked to provide information about their products. And if you want to trial or use a spinal cord stimulator in Australia, you have to register it with the Therapeutic Goods Association. So this review is going to be looking at things like indications and contraindications for use. They're going to want information from manufacturers about domestic and international incidences, adverse events, and complaints. And they're also seeking information on what corrective actions have been taken by manufacturers in response to investigations of adverse events and complaints. So where does this leave us? Well, the TGA is going to provide updates and outcomes of the review as they become available. They say they're going to provide or publish information about each spinal cord stimulator model as the reviews are completed. Now, the 2023 Cochrane review findings have actually already been submitted to the Federal Department of Health and Aged Care. They have a prosthesis list review task force, and the task force is reviewing the eligibility of current prostheses subsidised by Medicare, and this includes things like spinal cord stimulators. Overall, spinal cord stimulators are probably going to come under more scrutiny from both traditional and non-traditional sources. So today what I've spoken to you about is basically one part of evidence-based decision-making process, which at its core looks at three sources of information: the best available evidence. It also takes into account patient values and expectations and relies on clinical expertise. So basically what I've shown you today is that the best available evidence reveals a somewhat limited evidence base, not that many randomized control trials. The randomized control trials that have been published are lacking in terms of quality. There's a lack of long-term studies into the effectiveness of spinal cord stimulators. And as it stands, the two Cochrane reviews that have been very recently published don't come out and exactly endorse the use of spinal cord stimulation outside clinical trials. Now, I need to point out that an evidence review in and of itself is unable to answer the question around whether spinal cord stimulators should continue to be used in Australia, but it does raise concerns and points to the need for more information. So now what I'd like to do is to introduce Hugh, and Hugh is going to talk a little bit more about the policy implications and the use of spinal cord stimulators. Over to you, Hugh.
Yes, thanks, Sophie, and what a great presentation. I wanted to give some perspective of why WorkSafe Victoria asked ISCRR to undertake this literature review. I think the media attention and some of the issues raised in Sophie's review demonstrate exactly why we needed to do this. But we need to look at the context too. We have a large number of our injured workers who have chronic persistent pain, desperately seeking an answer. And we have pain specialists who have a tool that they would like to use. And there is an important understanding that we have to make when we're considering these requests. Our decision-making process or our approval process is quite detailed and complex. When we require a lot of information from the pain specialist if they're seeking to use a spinal cord stimulator for their patient. We require, as I said, a lot of information and a lot of assurance that all other efforts have been made that may be of benefit to this, to the patient, this injured worker, prior to considering spinal cord stimulator. And there are some definite goals that the pain specialists believe they can achieve. And when we're assured that all of those issues have been considered, we may then proceed to approving a trial. And the process is of a trial where the injured worker, the patient, is admitted to hospital and has the leads inserted and an external device attached, and they're monitored with outcome measures over the next 1 to 2 weeks usually. And if their pain significantly improves, the pain specialist makes a further submission to WorkSafe, and if the improvement has been significant enough, we will approve the permanent placement where leads are inserted and the generator is implanted. As we consider this evidence, it's obvious that these injured workers are among our most complex in the compensation system, and their claims have been present for some time. There's some time between their injury and this request for a spinal cord stimulator. Most have been unable to return to work because of their pain condition. And in our domain, the rates for requests for spinal cord stimulators are continuing to rise. And in fact, neuromodulation, which is the sort of the overarching terminology for the use of these electrical stimulation to alter the function of nerves, neuromodulation itself is rising, and in fact, it's a global trend. And it's been explored for issues beyond just pain and peripheral. It's being used for not just central pain, but peripheral pain. But beyond that, it's also being explored for its use in bladder dysfunction and bowel dysfunction and migraines, amongst other clinical conditions. But back to our spinal cord stimulators, Sophie mentioned a cost and mentioned the $30,000 for the device and the leads. But the actual cost of the trial then going on to a permanent placement, because it involves hospital admission, it involves the doctor's time and skill and the anaesthetists involved, it can rise from that device cost of $30,000, and the scheme costs can vary, but upwards of $55,000 to $70,000 for that trial and permanent placement. So it's not an insignificant process, but that's just the start, because we also have to be mindful that there is a long-term management cost, both financial, but also there's a burden on the injured worker who's having the spinal cord stimulator in place. We've also identified that patient selection is an important issue, and we reviewed our data in WorkSafe Victoria last year and looked at the progression or the successful progression from a trial with at least a 50% improvement in the pain or other factors such as function and opioid reduction from the trial to then go on to a permanent. So that as we analyse the success of the trial, in years gone past, that progression was deemed to be successful. The trial was deemed to be successful in about 70%. But for some reason that we can't quite understand, that rate has dropped down to about 50%, suggesting that patient selection isn't as good as it was in the past, or there have been some technical issues that have arisen. And so that also provides a focus for improvement. For the pain specialists, the focus, and we've seen in most of the research, it's been on short to medium term effectiveness of this treatment. And although there is limited evidence, there is some demonstration that it has been effective in those domains. But we also need to focus on the long-term outcomes, and that's our particular concern. And it's not just a return to work focus either, but the general well-being and lifestyle improvements for those patients who've already had a particularly difficult journey. We, of course, have to be responsible in our approach and rely on the best available evidence. And we now have to monitor the TGA's response, reflect on the literature review that Sophie's presented. And there's a further development and an encouragement, particularly by the Neuromodulation Society, to develop a national registry for spinal cord stimulators. And I think this is an essential step to develop a greater understanding of this treatment. So my final comments are, what are the next stage? And the next stage of this project, having completed the literature review, is to look at WorkSafe Victoria's own injured workers who have been in our system for some time and had a spinal cord stimulator inserted. Similar to some recent published work on WorkSafe's injured workers who had a lumbar spinal fusion, we're now seeking to understand the long-term outcomes of those who've had spinal cord stimulators inserted. What are those long-term benefits? What are the actual improvements? And we don't know that yet, and we need to explore that. And what's the additional procedural burden among these people who've had a spinal cord stimulator? And perhaps there's a middle ground here. There are certainly those who believe we shouldn't be using spinal cord stimulators, and there are advocates that it's a great tool. But is it a true long-term tool, or is it a medium-term tool that enables improved function and rehabilitation? So then the injured worker can self-maintain their long-term welfare. That's another aspect that we must consider. And we're also looking at prospective monitoring and developing our own internal registry. Whether or not a national registry gets up and running, we don't know, but we need to have an ongoing registry so we understand the burden of the treatment and the benefits of the treatment when a spinal cord stimulator is used. Thank you very much. And again, Sophie and Janine and your team, thank you for that great presentation and the hard work to produce that literature review.
Thanks so much, Hugh and Sophie, for great insights and great context here. We've had lots of questions come through. If you do have a question, you could submit it on the Q&A, but we probably don't have a lot of time to get through what we have. Just first, Hugh, what's the how useful do you find the evidence reviews in making decisions for WorkSafe?
Invaluable. I think one of the great ways of using evidence like this is our clinicians, perhaps I'd describe it this way, our clinicians who review the spinal cord stimulators have a high degree of skepticism when they approach a request, and a concern that this has got to be established to be the right form of treatment for us to approve it. And then they can revisit it after the trial before the permanent is approved. So what this demonstrates is that their skepticism is in fact well-founded. And we need to ensure that treatment that we're approving is going to really be of benefit for that injured worker. So that's where, in particular, this literature review will be so helpful for us. Excellent. Thanks, Hugh. There's been lots of discussion in the chat and the Q&A about the effectiveness of spinal cord stimulators. Sophie, there was a question about a lot of the systematic reviews are saying that they are effective for the spinal cord stimulators are effective for pain, but yet the Cochrane reviews are saying there's no evidence. Can you explain that, please?
Sure. When we look at Cochrane reviews, these are really the highest standard in evidence-based healthcare reviews, basically. They assess number and quality of randomized controlled trials, and they apply quite a rigorous methodology to evaluate these randomized controlled trials. Systematic reviews that you often find in the literature don't necessarily adhere to those very high standards. So that's one reason why sometimes conclusions can be stronger coming from the Cochrane, because they are in fact taking account of various limitations in the publications that they are reviewing. Now, the 2021 Cochrane review by O'Connell and his colleagues, they did conclude that spinal cord stimulators may reduce pain intensity in some people with chronic pain, but because of the quality of those RCTs that they based that on, unfortunately, they weren't able to conclude with any great certainty that the improvements weren't also likely to be caused by another factor, and that factor mainly being a placebo effect. And that's also what the 2023 Cochrane review concluded. There's just not enough evidence to suggest that spinal cord stimulators are more effective than a placebo. So essentially, you will get different papers that come out and have slightly different conclusions. And as I mentioned in my presentation, part of the problem of understanding the evidence base as a whole is the really high heterogeneity amongst all of the research. And so you are comparing different stimulators to different population groups under different conditions. And so you will get some differences in the literature. But ultimately, when we're seeking answers to important health device related questions like this, we are going to turn to more authoritative sources and more quality systematic reviews, such as the Cochrane reviews.
Excellent. Thanks, Sophie. One of the questions that came in quite early was that, Sophie, you mentioned that they do a 1 to 2 week trial first, and I know Hugh talked about this as well. And someone's asked how it's judged whether there's a 50% reduction in pain. You might be able to answer this one, Hugh. You're on mute.
Some of the clinical panelists, the physicians within TAC and WorkSafe, have developed an outcome measure booklet that covers both pain reduction and function and lifestyle issues in one broad approach. And so we ask that all physicians who use the spinal implanter trial spinal cord stimulator use this booklet of outcome measures to assess. And so what we usually see is once the trial's been done, the same outcome measures applied from patient to patient for us to assess.
I might just add further that in the literature, one of the issues is variation in the measurement of pain outcomes. So we see different measures of outcomes by different papers. Some of them look at visual analog scales and other look at other measures. And one of the suggestions sort of I've seen lately is that we need more patient-reported outcome measures to be used in clinical trials rather than just the standard visual acuity scale of whether or not you can tick the 50% category.
Excellent. Thanks, Sophie.
Can I just chop that up? As we look at the review of how our injured workers have progressed over the longer term with spinal cord stimulators, because they've almost all of them have used the same outcome measures booklet at the time of their trial, we hope to be able to revisit that same measure now at that longer term period and be able to compare those two. So there's we do have the benefit, as we're doing this study, of consistency of those outcome measures.
Excellent. Thanks, Hugh. We're actually up to time. So, yeah, thanks so much for everyone for attending. If anyone's got any pressing questions that we haven't answered, because I know there's quite a lot have come through, feel free to email the ISCRR the info@ISCRR email address, and we can certainly answer them for you. But yeah, I'd like to thank Sophie and Hugh again for great insights, and thank you to everyone for coming. Thank you.